So thanks for this opportunity, Srinivas and Madam. And I would agree with Chaitra in a lot of things that she said. But we should also agree that ICGA is a gold standard, more expensive than gold to manage one or buy one equipment actually. So in all invasive procedures, we should not only end up managing the disease, but we end up managing patient also and the patient expectations. So apart from the risk of anaphylaxis, vasovagal, etc., so it needs an anesthetist to be around. And we'll also get some very queer situations where one of the patients called me about 11:30 in the night as an emergency. And he said, my urine cleared up because I had told him that your urine may be colored after a FFA ICG for about 24 hours. So these are the situations that we may end up with. So thanks to Chaitra and Unni that my job is made a lot more easy. I am going to allude to this particular paper. Seems to be the best paper ever so far in giving us how to use the OCT for a diagnosis of PCV. So they have given basically some biomarkers, we may call it so. When we combine with the clinical picture and the vision and etc., we can, with a reasonable amount of certainty, with a sensitivity and specificity of close to about 90% and a positive predictive value of close to about 93%, we can conclude that the lesion that we are seeing is PCV. However, the negative predictive value is close to about 68, and any absence of these lesions does not really rule out the disease. That is probably when we may have to do an ICGA, not routinely. So let us quickly go through what are these OCT kind of biomarkers to indicate towards the PCV. If we see a sharp peaked PED in the inverted V situation and sub-RP ring-like lesion, which is little hyporeflective in the core, multilobular PEDs, double layer sign, of course not very specific for PCV alone, we can see in other diseases also, a thick choroid, this can indicate to PCV. Fluid compartment, we see more of SRF compared to IRF in PCV versus the AMD, and NFAS OCT complex RP elevations. So apart from giving these 7 to 8 OCT biomarkers, they also change the nomenclature. So the polyp is no more a polyp, it's a polypoidal lesion, and the BVN is a basal, it's a BNN now. And the fundus pictures, when we see extensive subretinal hemorrhage and the orange nodule, this is when we are thinking that the lesion is a PCV. So this is the picture which I borrowed from the same article, kind of gives how this sharp peaked PED looks like, the multilobulated PED, the thick the choroid, the double layer sign, and the SRF being very, very prominent, submacular hemorrhage and an orange nodule. So several groups have kind of used a combination of the OCT features, but some of them have reported the specificity to be close to about 90%, which is pretty good, especially when you don't have access to OCT. And these are all the other lesions that we can look at on the OCT. So let us go through a case example here. This is a lesion. You can see the BNN on the OCTA. This is just to correlate that what you see on the OCT and the OCTA, they're not really far away from each other. And this is the area of the BNN that you can see very, very clearly with the DLS and SRF. And we can, in these kind of cases, very predictably make a diagnosis of PCV. A case example, this is a baseline macula, and on top you have after the treatment with an anti-VEGF agents. So OCT not only gives an ability to make a diagnosis, but it also gives an ability to keep repeating it and monitor the patient's progress, especially in response to anti-VEGF agents. This is one more case example. The OCT shows good resolution after anti-VEGF treatment. You can see that the hyperreflective foci, the intraretinal fluid, and the PED resolved well. The correlation with the OCTA, you can see a polypoidal lesion here and the BNN, which resolved very well after the treatment with anti-VEGF. So OCT basically not only helps you to make a diagnosis, it also helps you to monitor the patient. It will tell you when to treat, when not to treat. You can actually make a distinction between good and the bad prognosis, which is not possible with an ICGA. Thank you.
Thanks, Bhargav. Chaitra and Bhargav, both of you are really good. Srinivas?
I think I'm a little bit biased, madam, because of course, Sri Bhargav's a wonderful presentation. You countered it. Being in an institution when you have an ICGA, and definitely people tend to use ICGA, so I'm not a good judge to judge this debate. But any of our panelists want to make any comment quickly on both these debates. I think Dr. Kumar has raised his hand. I'm sure that he's going to bat for OCT definitely. Yes,
We have
Kumar.
not heard Dr.
No,
Cairo.
no.
Karobi
I won't side any one of them. All I wanted to say was debates are expected to be a little more animated and vociferous. It was a very friendly debate. I was expecting each to go for the other's jugular.
They're friends, sir.
Very
Yes,
true.
Karobi madam, go ahead.
Very nicely presented, both of you. I mean, good points, like, brought forth by each one in their own defense. But the thing is that the problem with these debates is nowadays, with the advent of new anti-VEGFs and forthcoming more anti-VEGFs, there is not even any necessity to know the disease type, forget the investigations, because the same molecule works for just everything.
I think
Parveen madam.
charm of ICG was for
It's 7 o'clock.
Definitely needed. And for focal laser also, beyond the anti-VEGF, if there are some points where we actually need it is, extrafoveal polyps, where we can just do a focal laser and we're done with it, which you can never pick up that confidently on any other imaging device. And for PDT, of course, right now we don't have access, but I'm sure we all miss PDT. It was so good when it was there.
So what do you say?
I absolutely agree with this.
Extrafoveal polyps, they respond very well, and with large hemorrhages also, they tend to clear with just the laser treatment that is given to them. What you say is right. See, everything has its own plus and minus points, but it's the general observation where people may have the modality or may not have the modality. It depends on that.
One more point I would like to make is I completely agree with Chaitra, especially with extrafoveal polyps. We need to do an ICGA to pick up, and a simple laser will give a more permanent cure. And also, I would like to avoid anticoagulants for these patients, especially in the elderly age group. Nowadays, a lot of people are on anticoagulants, and that increases the risk of massive submacular hemorrhages. I think that is also one point which can be picked up by the ICG, especially if the disease being bilateral.
The way I would say that, though I would agree that if you're looking only at OCT, then no, OCT alone may not be sufficient, but OCT angiography pretty much completely eliminates the need for an ICG system today. Because the OCT angiogram, you can see the vessels at all the various levels, and it's highly repeatable, and it is very accurate. And even for focal treatment, ICG, Octa can be used very, very effectively. So that's so that's why I was saying, even in the earlier paper, don't just do the OCT, look at the OCT angiogram, and the two aspects to it. Number one, is there still a need to identify the focal? Well, Dr. Chaitra has well mentioned that yes, there is a need to identify these lesions focally so that we can treat them focally. And the second part is that can we do it with anything besides doing an OCT angiogram, besides an ICG? Then the answer is yes. OCT angiogram can do that job very, very well.
Okay, thank you, Usham sir. As we are running really short of time, quick comment from Parveen madam and Reema madam. They wanted to make a point.
Yeah, so I think I agree with Chaitra. There is definite role of ICG still where PCV management is concerned. But the only point to be remembered now is that our job has been made easier and we can still treat PCV based on OCT and OCTA, especially the structural and fast OCTA can really help in addition to our regular OCT scans. So that's the only thing. But if you have it, please use ICGA. It will definitely improve, especially in presence of massive hemorrhage. OCT and OCTA is absolutely useless.
Absolutely. I think that's the main thing. Which is the salient feature. We see massive exudation and hemorrhages, which is when both OCTA and Octa become very difficult. But one thing I'd like to add here is that you have wide field Octa coming in now. I think that's again going to be a big game changer. We can even look beyond, the arcade a little bit. Thank you.
Thank you, Dr. Chaitra. Quick comment from Reema madam, and then we'll move on to the next case.
I think we're
Yeah, Reema madam.
my points have been covered by Dr. Praveen. This is what I wanted to say.
Thank you. So very nice after 5